I just want to thank everybody for coming this morning for Dr. Pelto's lecture. Just real quick with Dr. Pelto, he's been a great partner of Greendale Physical Therapy for many, many years, and I really appreciate him coming out on a Saturday morning to share his experience and share with everybody what his knowledge base is. This is just a quick opportunity for me to talk about Greendale Physical Therapy with a captured audience. Greendale Physical Therapy is, I think most of you guys know, it has 6 locations in Central Massachusetts with 2 in Worcester. We have a new location going in Auburn, Massachusetts. Growth is something that's important for a business, but we do it really thoughtfully. We don't go crazy with it. So it's a really nice location for Auburn. We have some great therapists going to that location. And also just to let people know a little bit about our services. Sports and orthopedic is our primary focus, but we also have right across the street a neurological balance and vestibular center. It's the only one of its kind in Central Massachusetts. We see a lot of people with neurological conditions, balance issues, amputees, that type of thing. So we have that as well. Thank you for coming. I really appreciate you coming out on a Saturday morning, and I'll hand it off to Dr. Pelto.
Great. Thanks, John. I want to thank, once again, everyone for coming out. I'm going to move this over here so I can see it a little bit better here. Okay. Because it's hard. I think what you should do next time I come, John, just buy a big screen TV. It'll just solve the problem. Just a huge... It would be. It would. There's no light changes. Kind of like, so then we could come here and watch the World Cup. So you'd have to do that too. That would be great. You could send out invite. We could fill this place up with World Cup, and then we'd treat all the foot problems that happen after the World Cup. New business model. Well, welcome everyone. I see some of my patients here. I'm not going to say who they are because of HIPAA, but I see some patients here. I see others that aren't patients, but I feel like everyone is everyone either dealt with plantar fasciitis or is dealing with plantar fasciitis or works with people with plantar fasciitis. Raise your hand. Okay, so everyone's heard of this word. You know some people that have had it. So I'm going to talk a little bit about plantar fasciitis, kind of what works in my hands. Now this, I know there's some PTs, and usually when we go to lectures that are academic, we tend to put all the articles, and basically you go from one article to another article to another article. We are not doing that. If you want the references, I can certainly give them to you for some of the PTs that are interested in these things, but this is going to be for a lay audience, so it's more educational. I'm really simplifying it, so for some of the PTs here, it's going to be like, that's real simple. But I think with our patients, we have to simplify it because they do not understand big words. And there's only one slide with big words, and I'm going to go in and explain that. So what works for plantar fasciitis? So just rolling it on a tennis ball doesn't work. Searching Google, or these days, hey doc, I put it in ChatGPT, that doesn't work for healing Achilles tendinitis and plantar fasciitis, despite how much we think that it will help us, because it comes with some good information, but it's the sequencing of that information and knowing what's most effective and least effective is how you treat it.
That's why you need YouTube.
But even YouTube, I have many YouTube videos and I try to explain it, but each provider will treat it differently. So depending on the specialty that you go see, you might see these days, what I really appreciate about PT is they can do direct treatment. So they are doctors, and so patients can go directly to PT. And then maybe the PT will work. Then if it doesn't work, then they're usually sending it maybe to a podiatrist. Sometimes they go directly to the urgent care and they give them a little handout and they say, do these stretches. And if it's not getting better, go to see your primary care. Then they go to see the primary care and then they do the stretches. And then if it doesn't work, then they'll send them to PT or they'll send them to us. So there's a lot of different people that can treat plantar fasciitis and Achilles tendinitis. You might be wondering why I'm putting them together, because in my practice, I treat them basically the same way, except for a couple of exceptions. They're very, very simple, similar in terms of the treatment. They're not simple. So I'm going to go through a couple of cases. This first case is a long-standing Achilles tendinitis. There's a 43-year-old male. He had a 3-year history of Achilles pain. Many times with Achilles tendinitis specifically, patients just live with this for years because they go to a doctor, many times either a podiatrist or an orthopedist, and they just say, well, I've done everything I can. What is everything I can? Everything I can is I sent you to PT and you didn't get better, so you just have to either wear a walking boot or live with it. That's what they say. And so people get frustrated and they just believe it, right? Because you're getting it from a medical professional. And so he was dealing with this for 3 years. He went to PT, had an MRI, had a partial tear, called a partial substance tear, and thickness of the Achilles. Because of the tear, he got an MRI, and they just said, well, you just got to wear the boot, the walking boot. And does walking boot heal a partial tear? The doctor didn't know, and he was in that forever. It threw his hips off, because usually when you're in the boot, it throws you off. So a tip to the PTs is get them an even up, which is something they can put on the other foot if they have to wear a walking boot. And he came to me, and I'll show you an example here. It's really hard for you to see this, but this is the Achilles tendon. And here it looks like kind of like a bulb, we call it. That's a bulbous change. And this is measuring, I think it's about 9 to 10 or 11 millimeters. So it's about double the thickness. You could just cut it in half, and that would be about a normal Achilles tendon. So he came in with something like this. Black usually means inflammation of the tissue or water that's in the tissue on the ultrasound. And we did Shockwave, which I'll talk a little bit about. And at the 12-week follow-up, he continued to have pain because of that tear. And that's where we're going to do something called an amniotic stem cell in there, because he didn't have the building blocks. That's what the amnio does, is it helps put the building blocks. You can do amnio, you can do PRP, and things like that. You may hear about those things. I think amnio is a little bit easier for me because I don't like drawing blood. In PRP, you need so much of it. Platelet-rich plasma. So you're taking the blood and you're spinning it down and grabbing the platelets and injecting it. Amniotic, it's not really a stem cell, but you're taking the amnion from a donating full-term birth, and it has really potent cells for healing, growth factors, and you take a little bit of that and you inject it into the area that isn't healing. And we'll talk a little bit why the plantar fascia and the Achilles tendon doesn't heal. So this gentleman's feeling better. This is that little tear right here on the ultrasound. We can see this little black area. And the way I think about plantar fascia and the Achilles tendon, the Achilles specifically, it's kind of like string cheese. My kids like the string cheese. And so usually the tear isn't straight through unless you're rupturing it. Usually it's like when you pull the string cheese and it kind of breaks apart. That's called a longitudinal tear. And that's more common. And then those just don't always heal, but there's no great surgical way of healing it. You're not going to we call it sew it up. If it's in the middle, it's hard. If it's on the side, you can just remove that portion of the tendon, and we call retubularize, and I'll explain that a little bit because it turns flat and you make it a tube again. Okay, so this person got better. This is the second case. This is a bilateral, meaning both foot. He's a 50-year-old man. He's a financial planner. He's had 3 years with Achilles tendinitis on both feet. This guy was just hobbling around for years, and he didn't know who to go to. He went and saw some people, couldn't get better. He really gave up. And he came in, and I tell you, I have these patients that say, oh, by the way, how about my nail fungus? Oh, by the way, how about my ingrown toenail? Oh, by the way, how about... Because once you start healing one thing, then they want to do everything. But we did 6 sessions of Shockwave on both sides. He started to feel better by about week 5. One of the biggest things is most people, when they're doing, this is considered regenerative medicine, it takes about 6 weeks for people to see improvement. And the reason is I'm taking something there's different types of tendon injuries. One is acute and the other is chronic. So I'm keeping it real simple. For acute injuries, most things should get better in 6 to 8 weeks. Okay? So if you go somewhere, you hurt yourself, 6 to 8 weeks, most acute things, if you have the normal healing process, it should get better. So that's where people ask me, when should I see someone? Well, I always joke, if you spent more than $300 and it's been over 3 months, you should probably see a specialist. Because people these days, they think with ChatGPT and Amazon, they can heal everything. So everyone comes in, I got these 5 foam rollers, with one with vibration, and I have this stretching tool, and I have this Theragun, and I have this little slant thing that I'm using. I have these Kuru shoes, and I have all these other shoes you can get on Amazon. Because when you put in plantar fasciitis or Achilles tendinitis, all these advertisers, and they say it's the best thing since sliced bread. So if you spend over $300 over 3 months, it's cheaper just to see a specialist. Okay, don't spend, you can't outspend these conditions. So they were thick on both sides. He's starting to feel better. And this last one, this is a 37-year-old female. She is a lawyer, and she was seen by me a year ago. She had plantar fasciitis, and at that time, she just wanted a cortisone injection. And she came in, she researched it. I'm young, I just want the cortisone. And we did cortisone, and then the pain came back a year later, okay, time later. I only do cortisone these days when someone has a big event coming up. Let's say they're going to go travel to on vacation. Let's say they're going to be in a wedding. Let's say they just need to function. So occasionally I'm doing cortisone. I don't do that much cortisone because it tends to make it feel better, but it doesn't heal the tissue. That's the key. And I'll show you the difference in the tissue, how the tissue actually changes. So she was seen a year ago, and she's like, hey, can I just do another cortisone? It worked for me before. I'm young, I'm 37, I'm busy. I said, we can do it. We did a cortisone. She came back a couple weeks later, wasn't better. She said, well, I'm still young, I want to go to PT. We went to PT, and then she came back and she still wasn't better. And then the reason it wasn't the problem with PT, the problem was her plantar fascia. So her plantar fascia was very, very thick. It's hard for you to see that, but it usually looks like I always say like a piece of celery, like a straight piece of celery, but it had this almost like the same way the Achilles gets bulbous, the plantar fascia gets bulbous and thickened, and that's why it didn't get better. So we ended up doing the Shockwave, and she starts feeling better by about week 5, and now she can walk and she can do things. Okay. Okay. So what is the real problem? Now, heel pain is one of the most common foot pain things that we see in our practice and PTC. And the problem is people tend to deal with this too long. They just think if they give it more time, it will get better. And I think we are all guilty of that. So we just want to give it time. Time without doing any treatment, I don't think is a good plan. So time without treatment isn't a good plan. Time with treatment, that makes more sense. So I'm going to cover here, I'm going to say what I'm going to cover and not cover because of time. So I'm going to talk about plantar fasciitis and Achilles tendinitis. And it's associated with a Haglund's deformity, which is basically where the Achilles inserts in the back of the heel and there's a bump. Some people have a bump back there. And that they're all kind of treated about the same. I am not going to treat or talk about Severs. So Severs is a condition that children get when they have a growth plate and the Achilles tendon pulls on the growth plate in the back of the heel. So they come in thinking they have plantar fasciitis. Kids don't get plantar fasciitis. They get Severs. Severs will go away on its own. The problem is most kids these days are one sport kids. Usually it's the kids that are in gymnastics because they're barefoot and there's a lot of impact. There is kids that play soccer and they just go and it never calms down. So the same treatments that I'm talking about for heel pain work for Severs, okay? Like I had a national gymnast that came in for Severs. He had the Shockwave, he got better, but there's not many great options for Severs other than that. We're not going to talk about bursitis. You can get hip bursitis. You can get bursitis around the back of the heel. Those things, they do resolve also with these treatments, but I'm not specifically talking about that. I'm not going to talk about heel spurs. I don't think heel spurs are really the culprit. We used to think that heel spurs were the problem, but that's what people can see. So they go see a doctor and they look and they say, oh, by the way, you have heel spurs. Heel spurs aren't the problem. Okay, heel spurs are a sign of the problem, and the problem usually is tightness. Okay? And everyone says, I'm not tight. Most people are tight. Usually the problem is tightness. I'm using the word tightness for the PTs. The problem is equinus, okay? But it's tightness. So that is the underlying problem for Achilles tendinitis and plantar fasciitis, is tightness, okay? And you don't feel like you're tight, but most of us are tight, most likely because we're sitting down all the time, and then we do a lot of activity on the weekend, and things flare up. We're not going to talk about surgery. I hardly do surgery anymore for these conditions, so because you don't need it. They get better without surgery. I almost say that these regenerative treatments are almost like a scalpel. It's that precise, some of these regenerative treatments. So how common is heel pain? About 10% of the global population has it. 1 in 10 individuals suffers with heel pain. Runners, about 50%, develop it. Sometimes it goes away on its own, sometimes it doesn't. And before we go into anything more, I want to explain, this is something I didn't understand. This is called the dysfunction symptom index. Okay, it sounds really academic, okay, but it's just a way for me to explain things to patients, because everyone asks me, how come I've been good my whole life and now all of a sudden I developed plantar fasciitis or Achilles tendinitis? Or how come I had it once and it got better and now it came back? Everyone asks me these problems, asks me why this is. The easiest explanation is this. And so when I'm with patients, I'll usually use my example of my table. I'll say, on the x-axis you have your age, okay? We're all getting older right here in terms of age. And the y-axis you have dysfunction, okay? Dysfunction. And then this little line is the symptom line. So the way I explain it is, and this is my joke for PTs, if you go to a good physical therapist, are they going to find dysfunction? Yes. Does everyone have dysfunction? Yes. We all have dysfunction. Sometimes it might be hip mobility, sometimes it might be core weakness, sometimes it might be tightness somewhere. But do all those areas of dysfunction cause symptoms? No. Okay, so most people, the general population, they live their whole life and they don't go into the symptom. Okay. What we see in our clinic is a subpopulation, not the majority, because not everyone has plantar fasciitis. Not everyone has symptoms. Okay. Most people have dysfunction. So I'm going to go over some of the common dysfunctions that people have, and then if you stack one dysfunction on top of another, then it might lead to symptoms. Does that make sense? Okay, I think this is like the most important thing for you to understand in this lecture. So some of the dysfunction that people have, they might have flat feet. That is an area of dysfunction. If you have a young kid with flat feet, they might not have any symptoms. Okay, the parents put them in track. Okay, they start to use it a lot. They start to have more movement. All of a sudden, they develop symptoms. Okay. Did they have the dysfunction before? They did. They just didn't have the movement that made the symptoms worse. Okay, simple thing. Pronation, same as flat feet, so just that's where your foot flattens. Less movement. Patients, they might have surgery. After surgery, they're moving a lot less, or they have an illness, they have COVID, and then all of a sudden they want to get back to their activity. So they have more movement, things get tight. Okay, that can lead to symptoms. The main one, I think, is equinus, or tightness in the back of the calf. Calf tightness. Everyone is tight in the back of the calf. Doesn't usually bother people. But all of a sudden, they say, I've been on this treadmill going about 2 miles a day. All of a sudden, you know what I'm going to do? I heard someone say I should go with a really big incline. So I'm going to go 40 minutes on an incline. And all of a sudden, they develop Achilles tendinitis. Why? Because they went into that symptom realm. They already had the tightness. They just went into the symptom realm. Shoes. Everyone's hearing, I usually wear a New Balance or an Asics, and everyone's been talking about these minimalist, zero drop type of shoes that are really flat. All of a sudden, when you do that, it's going to put more strain on the Achilles tendon because of the tightness. And so they develop Achilles tendinitis. So they change shoes. A big one I hear is, I went to Disney with my kids and I was wearing flip-flops all day. Okay, they're walking 4 or 5 miles and all of a sudden everything hurts in their foot. They can develop any umpteen types of tendinitises that they can develop. So all these things, the foot deformity, impact, a lot of people they were in nursing school and now they become nurses and they're 8 hours a day at the hospital and they're on their feet on these hard surfaces. All of a sudden they start to develop symptoms. So a lot of it is because the dysfunction kind of goes up. Now, there are a couple of things that the PTs are going to like. They may have some core instability. They may have some proximal weakness. There might be something with it we call kinetic change, how everything connects together. These, when you increase movement, they can cause symptoms. So what happens is you get to a certain age, you increase your movement, you go into the symptom realm. Okay, and that's when people usually look for help. Okay, but a better example is this. So this is what I see. People, they say, hey, a couple of years ago, my heel started to hurt. So what did I do? I started to stretch. So hurt, I started to stretch, the symptoms went down. And I thought I was fine. Okay? And then 6 months later, all of a sudden it came back. Why? Because the dysfunction stayed. They may have tried to do some stretching, but then they went back into the symptom realm. And the second or third time, the tissues actually change. And I think that's the second big point, is we're going to look at how the tissues actually change if it's been inflamed for a long time, a chronic inflammation. Does this make sense? So this is not just for foot. This is for anything in your body as we get older. So this is just a very good explanation for patients of like, hey, nothing really changed. How come this happened? Well, it's because of this. Mm-hmm.
Is it right to take a photo?
You guys can, you can have the slides. You can take photos. I'll give you the slides after if you'd like to use this. So when I explain this to patients, I usually like take the table and I say, this table is your symptom line. Here, and you just walk patients through, because everyone asks us, why did this happen? Like why didn't it happen when I was 40? Why is it when I'm 60? And why does it come back? This is why it comes back. Okay, so it tends to be a cycle of disappointment. Many patients experience recurring heel pain, and they've tried different types of treatments, and this leads to frustration, a sense of helplessness in managing their own condition. And then patients start to try things. And so both for plantar fasciitis and Achilles tendinitis, they try the same thing. They try icing, they try heat, they try shoe inserts, prefab inserts, spend lots of money. They try dry needling, maybe with a PT. They'll do massaging. They'll try anti-inflammatories. They'll try night splints or rest splints. They'll try walking boots. They'll try cortisone injections. All these things, sometimes they work. The symptoms will go down. They might be fine. But the ones I see are the ones that they come back. And then they're like, why did that come back? Can't you just do the same thing that I had last time? Why isn't it working? Okay. So the first thing is the symptom. I think that's real important to understand how that happens. The second thing is tissue, like the plantar fascia and the Achilles tendon, is different tissue than other parts of our body. So let me give you an example. Do you ever hear of anyone saying, you know, I got this muscleitis? Do you ever hear of a muscleitis? No. Do you ever hear of a tendinitis? Why don't you have muscleitis? Okay, let's look at tissue. Let's talk about tissue. So this tissue back here is called what? A tendon, Achilles tendon. This tissue down here is called the plantar fascia. Real simple. If you look at it, what color is it? Huh? White. Okay. No, I don't have a picture of muscle. If you look at muscle, what color is it? What color is muscle? Red. Like when you make a steak, it's red, right? It's red. You don't like to eat the ligaments and the sinews and you don't like to eat that because it's like tough and stuff like that. You like to eat meat. So, or maybe you're vegetarian, but so muscle, it's red. What has better circulation? Red muscle or white tendon? Red muscle. That's why you don't get muscleitis. Another real simple thing I never quite understood. They call these things different things, okay? A tendon, the reason it's called a tendon is because it starts in a muscle and it goes into a bone. That's what means that it's the job. That's why it gets the name of a tendon, okay? Fascia starts at a bone, it kind of flares out. It's the job that it does that makes it a fascia. If you talk about a ligament, if I would have a ligament on this picture, a ligament would go from a bone to a bone, but it would still be white, but its job, it goes from bone to bone. That's why they call it a ligament. Let's take away the name. You take a piece of fascia, you take a piece of ligament, and you take a piece of a tendon, and you look at them under a microscope. Do you think they're going to look the same? Yes. They're going to look the same because they just do different jobs. They're the same thing. That's why Achilles tendinitis and plantar fasciitis, and a lot of these things, are treated the same way, because the problem with them, there's not enough blood flow. So instead of healing, they get injured and they get chronically inflamed, and there's not enough blood flow to go into them. So that's the whole problem about the tissue, is the tissue changes. Does that make sense? I'm really emphatic. I'm trying to make certain points. That's the second. So the big one is, first is movement, that it causes symptoms, and the second is it's the tissue. It's a tissue problem. Okay. Question to you: 6-year-old kid, okay, versus a 60-year-old. You think your tissues change over time? Yes. When you get 60, it looks like beef jerky. Okay. When you're young, it looks like a filet mignon. Okay. The tissues change because of the use. because of dehydration, because of you're just not moving, you know? And that's the challenge. So really easy way, now this is gonna be really hard, you can't see anything. So I'm gonna try to explain what you would see in this picture. So this is an ultrasound probe right here. I'm putting the ultrasound on the bottom of the heel. This is the fascia, okay? So what you're gonna see is this fascia is this thick, and this one has a different thickness. I wish I could, you can look at the pictures here afterwards. But this is a normal thickness, and this one is about double the thickness, okay? So the nice thing about ultrasound is when patients come in, you can look and you can say, you know, first of all, I always say for the patients, I'm gonna tell you if it's a boy or a girl when I do the ultrasound, and then the women tend to laugh. And then, because it's a diagnostic, it's not there's a difference between therapeutic ultrasound and diagnostic. This is a diagnostic ultrasound. I basically put it on the right heel and then the left heel, and if the painful heel is really thick, that means the tissue is chronically damaged. Real simple. It's not rocket science. It's not rocket science. That's why I think PT should own a little ultrasound. They're super cheap. You just hold it up. You can see the tissue's changed. That requires different types of treatment. So when I talked about that symptom index, the cause has changed, the tissue has changed. That's why it requires different types of treatments. When they both look the same thickness, then you can usually get by with just a cortisone injection. You can get by with physical therapy, with just stretching, and it'll be fine. But when the tissue changes, that's not going to work. Okay. And I guess people ask me about there's a heel spur there. You can't really see it. Heel spur isn't an issue. I don't treat heel spur. So can you see these? No, you can see the yellow lines. One was thicker and one's thinner. But the key concept, it's not just inflammation, it's what we call degeneration. So I'm going to make this point. So degeneration is disorganized tissue repair. So your body is supposed to heal things normally. When it's disorganized, it develops, the easiest way to explain it to patients, it's kind of like when you get a cut, and you can either get a nice little thin scar or you can get a really big scar, okay? The big scar is usually due to the damaged tissue repair, meaning there's a lot of movement, you're pulling it apart, you pick the scab off, you know, things like that, and it creates this big disorganized tissue repair, either because it opens up again and you close, kind of like if you open and close a wound multiple times, it's going to get a really big tissue inside there. Same thing with the Achilles and the plantar fascia, but you can't see inside unless you have an ultrasound. So the first, it has disorganized tissue repair. Second thing is it has reduced elasticity. Okay, this is really important. I remember my grandma. She was old, and she had one of these junk drawers. And inside the junk drawers, she had some of these rubber bands. I don't know if you've ever seen some of these rubber bands, but these are rubber bands that are like 40 years old. And I used to pull the rubber band. What happens to the rubber band? It snaps. What happened? You lost the elasticity. So 6-year-old kid, good elasticity. 60-year-old, you lose a little bit of the elasticity. And that's where you can get the little breaks or tears or injuries to the tissue, and then it doesn't have good tissue to heal. That's why sometimes you need to put in other tissue to heal. That's the amnio. But if the tissue's good enough, then you can just use the regenerative treatments. So if the tissue's good, you can use regenerative treatment, it'll be fine. If the tissue's bad, you need building blocks. Okay? It's kind of like if you go to the bank, you have to have money in there to pull out. Right? You have to have good tissue for it to actually heal it. If the bad tissue, loss of elasticity. So one of the biggest benefits of doing this treatment, which is when you whack the heck out of it, increases elasticity. PTs, they do this rubbing, the Graston technique, it increases elasticity. Okay? Go ahead.
And the Shockwave is the regenerative?
Yeah. That's the one that I use. It helps increase elasticity. So dry needling increases blood flow, but I think the other types of treatment increase the elasticity. So the key is elasticity. Now, if the elasticity is really bad, and we'll get into this, sometimes you can't make the Achilles tendon a lot more elastic. That's why I tend to recommend working higher up, so working on the muscle, because you can massage out the muscle with foam rolling, things like that. That can make the muscle looser, which will make inherently the Achilles tendon looser. Okay, go ahead. So amnio is it's like you take from the amniotic cells around a full-term birth, and you take these cells, and they have really good collagen, and we call growth factors. So you have better building blocks. So if the tissue is like a bad rubber band, you can put in better tissue, and that a lot of times helps it to heal the tissue. It's a shot. It's a shot. Yep. And so PRP, platelet-rich plasma, is where you take your own blood and you spin it down and you get the platelets, and that helps to heal the tissue as well. But it's only as good as your blood is. So as we get older, our blood isn't as good. So you might not have as many platelet cells, good platelets in there. Okay? They're not covered. A lot of these aren't covered, but people are suffering, and these work. So yeah, a lot, like Shockwave is not covered. PRP, amnio, these other things aren't covered. But I tend to see the real complex ones. They've been all around, and then they don't have hope. So, they work well. So reduced elasticity, and then the other thing it says here is they have micro tears. So what I'm talking, there's a difference between a macro tear, which is it cuts in half. Micro tears are small little tears, and then these develop little areas of scar tissue, and they get thicker and thicker and thicker. Okay, so this is the whole problem with plantar fasciitis and Achilles tendinitis. Is it reduces, it's all disorganized. There's no more elasticity, and then when it's thickened, if you think about it, imagine if you have one rubber band, okay, and you pull it, okay. Then imagine if you take 3 rubber bands. I always like it because you guys use the TheraBands here. You take the green TheraBand, and then you can switch it to the blue or black TheraBand, and they're a lot harder to pull. So you have increased hardness when you're pulling it, so there's reduced elasticity in that, which makes it more prone to tearing again. That's the problem. And another thing is, if you think about, for like the plantar fascia, the fascia is this flat thing on the bottom of the foot right here, and this is your arch. So if you step, it's going to pull it. Every time you're stepping, it's pulling and stretching that plantar fascia. That's why we use an orthotic. If you have a high contouring orthotic, that pushes up that rubber band, and so when you step on it, it's not going to stretch and cause tears to that fascia anymore. That's why we use custom orthotics that contour high to the arch. You can try over the counter, but they're mostly cushions, okay, and they never really contour high enough. That's the problem. But they're 10%, so they're $60 versus $600. So I always say, try the cheap one first. If that one doesn't work, then you do the custom one. It's not just the arch though; it's also stabilizing the heel. There's other things that we do with the inserts. Okay. Analogously to plantar fascia is the Achilles tendon. Okay, it has the same injury mechanics. There are 2 main areas where the Achilles can get injured. One is, we call it the mid portion of the Achilles. You hear about these people that are playing basketball on the weekend, about my age. I'm going to go play with my kids, do a layup, and you pop the Achilles. Once again, that tendon probably lost some of the elasticity as we're getting older. We're not used to using it. There's tightness, and then it can pop. Okay, not always pop. The majority I see aren't popping. The ones that pop, they have to have surgical repair. The ones that don't pop, they get little micro tears in there, and then they get thick. So if you feel someone's tendon, it's going to go like this, and then it'll go out, and then it'll come back in. So and you squeeze it, and it's going to hurt.
What do you mean by pop?
A rupture. So some patients tear, a rupture, tears totally through, and their foot drops, and then the basketball players get these, a complete tear.
That's a pop.
Yeah, and that can either be from bad tissue, or it can be from really, really strong person. We call it a propulsive type of a jump. Like they're jumping up on one foot, they're landing on one foot, they're doing these propulsive type of activities that can rupture through. It might not be because of bad tissue. They may have great tissue, but it just could be too much activity, or someone hits it in the back. You see this with soccer. They kick them in the back of the Achilles.
I've had a couple of patients with full tears,
Yep.
and nowadays I guess doctors are saying don't do surgery because down the line it's the same benefit of surgery. Have you heard of
Correct. So we do both surgical and non-surgical repair in our office. So
decide that?
So usually it would be the doctor's preference. Okay, so some put people in a really big boot that has a really high heel on it, and you gradually, as it's attaching, it gradually kind of go down. It really depends. 35-year-old athletes, you fix them. 60, 70-year-old people, you put them in the boots. So a lot of it is how active the patient is. Usually very active people, we are still surgically. You're not going to do a 30 or 40-year-old to put them in one of these boots and just say, hey, wait. It's more of the older people that I'm sorry to say that, but it's the older ones that aren't really doing the surgical repair. Makes sense? Because you never hear about pro athletes, not surgically repairing it. They're all getting it surgically repaired because it's the quicker recovery. So it depends on how quickly you need to be recovered. Yes, there might still be scarring in the tissue and things like that, but a lot of it's the quickness of needing to get back to activity. Okay. So this one predictably gets better with Shockwave. Predictably, unless it's too thick. Like some of them are just really, really thick. And so a lot of times it gets better, but it's still very thick. So you may need more treatments. Insertional Achilles is where the tendon inserts into the heel is a little bit more challenging because it's the tendon inserting into the bone. And the problem with both plantar fascia and Achilles, it's not like an arm doctor. They're just putting it into a sling or they're telling them not to use it. We're always walking on this. So you have an injury and then you're adding insult to it by walking a lot more. And that's the challenge with these types of conditions.
How does Shockwave work?
Yep, so all Shockwave does is it restarts the healing process.
So it stimulates something.
It stimulates your own healing potential. So normal things, I said this in the inflammatory system. So normal things in our body, most things, you think about, you break a bone. How long does it take to heal? 2 months. Any bone break, if they're in alignment, they're going to heal in 2 months. Tendons, usually, if they're going to heal in about 2 months. So if things take longer, then this is why I say 3 months or $300. If it takes longer and it's not healing, it's because it take it from an acute injury to a chronic injury. And when it's chronic, it means it's stalled. It's stalled. So all the Shockwave does is it just whacks the heck out of it. And it wakes up your body and says, hey, start healing it. The Shockwave doesn't heal it. It's not the Shockwave. It's your own body. It's your own body. It just wakes it up. That's all it does. Okay? Does that make sense? Okay, so for the insertional, I find this is a little bit more challenging. I was saying this before, but if you are considering regenerative medicine, you have to set expectations for patients. Okay? What I mean by that is it takes time. And many times I get phone calls from other patients wanting second opinions because the doctor wasn't very clear. And I'm very clear about this. They say, I did 3 sessions of Shockwave and I'm not better. I'm saying, when did you finish? Well, I just finished. Okay. So Shockwave, after the first session, you start to see improvement about week 5 or week 6 because that's the inflammatory cascade. And every time you're adding to it. So it takes about 6 weeks for it to start getting better. So if you don't feel anything for the first 6 weeks, that's normal. I tend to see that. I do 6 sessions. There's different ways of doing it. If I have athletes, I can do it every 72 hours because the inflammatory cascade goes down after 72 hours and I can retreat. So a lot of my sports athletes, they want to get better faster. They're college athletes and things like that. But after I finish at week 6, I see them in 6 weeks and I say, you're going to be maybe 50% better. That's all I say at week 6. But it'll continue to work in your body for 6 months. And then a lot of times at week 6, I do another Shockwave. Once again, if they pay for 6, I'm not charging for any future ones. I just do them because I just think it's the right thing to do. Then I'll do it in 6 weeks. I'll look at the ultrasound. How is it looking? Then I'll see them 12 weeks. And usually by 12 weeks, all of a sudden, what they tell me is, oh, hey, I'm starting to have more good days than bad days. We know that. We hear this from our patients. It's hurting less. I get up in the morning, it doesn't hurt anymore. I can do more activities. So my learning, and I've been referring to Greendale PT for like 18 years now. What they noticed, and some of you new PTs don't know this, but Don's referrals have reduced. Okay, and I'll explain why. It's because I used to do Shockwave and send everyone to PT. And when they came to PT, they came back to me and said, PT worked. And I said, really? I said, yeah. And I realized, because the timeline just takes more time, and you guys got all the credit. So I'm like, I don't want to give PT all the credit here. I want to start getting some of this credit. And so I did the 6 sessions, saw them back in 6 weeks, they were better. And as long as they don't have any other issues, like core issues, hip issues, other type of issues, I have to do a lot less PT. I feel bad for you, but it works so well, I just don't need it anymore. That's why I used to do Shockwave, and actually before I had Shockwave, everyone got cortisone injection, orthotics, and PT. That's what everyone got, that trio. Cortisone, orthotics, PT, okay? Once I realized that I could do this, and people were coming back because the inflammation was still coming back. So now I was doing Shockwave, PT, and orthotics. And I feel bad. Now I'm just doing Shockwave and orthotics, and they're getting better, and occasionally I'll do PT. I still do it for other conditions, but that's in my hands. That's why I recommend all the PTs here to do Shockwave. You should learn it. Happy to teach you. You have a bigger scope than I do.
I've heard mixed reviews from different patients about comfort level. Some say it's very painful, some say it's not.
Okay. I have 4 doctors in my practice with me. We're 4. Okay. Patients, it's how experienced. It's kind of like a PT. Some people can do the same PT and make you really hurt, and others don't hurt a lot. Okay. And it's a tool, and it's how you use it. So every year I at least go to 1 or 2 conferences on Shockwave. And there's some gentlemen, they're mostly males, that orthopedists from Germany. They come in and lecture to us because this started in Germany. The history behind Shockwave is actually it was used to break up kidney stones. So what happened is they put people in water and they shot sound waves. Lithotripsy. It's lithotripsy is what it is. And what they found out is people's back pain went away. And they're like, why the heck did their back pain go away? It's because it had that effect of helping the arthritis, because it does a lot more. I'm just talking about these 2 things. It can be used for a lot of other things. Their back pain went away. And what they've realized, and the more and more I go, is the lighter, you can still go lighter and they'll still get better. So my colleagues, when I first started Shockwave, like, people passed out. Like I thought they had to hurt for it to work. That's what I thought. That was 3 or 4 years ago. Now what I've realized, especially with like nerve issues, like neuromas or nerve entrapments, I go very, very light. I have a real simple system now. So if you can steal this from me if you do it. It's either going to be red, yellow, or green. Okay, if it's green, I want to go up into the yellow, but if it's in the red, I'm going to turn it down. So everyone is about a 5 or a 6 on a 10 scale. And so that's the way I do it. My colleagues still treat differently because they don't go to all the conferences, and so they're still making them hurt. So sometimes when I'm on vacation, they see one of my colleagues and they want to come back to me because I still get the results, but it doesn't hurt as much. So it's all doctor or the therapist, how you know how to use the machine. It's a tool, right? And like any other tool, you can cause injury with the tool, or you can use it for good. It's how familiar you are with that tool. Okay, like a scalpel, you can do good surgery, or you can be a hack. It's the same scalpel, but some people know how to use it better. Okay, so that's the Achilles. These are the micro tears, kind of an example of the micro tear. This is a little bit easier to see on this ultrasound example. This is what a normal Achilles tendon should look like. The other examples you really couldn't see is that it gets thickened like this. So when it gets little micro tears in there, instead of healing normally, it gets thicker. Kind of the same when you get a break in your bone, and you ever see the bone, how it develops like a callus around the bone? It's the same thing. It's this thickening around there. So usually Achilles is nice and oval and it's white. When it gets swelling, it turns black. So swelling, once again, when you see water, it's going to look black. That's inflammation, swelling or inflammation. That's why it hurts. So when it gets very, very thick like that, that means that there's little micro tears, and that disorganizes the collagen. So we haven't talked about these names, but collagen is what it's made up of, what the tendon is made up of. And this degeneration, which we talked about, slows down the healing, causes discomfort and different types of complications. So I'm going to talk about why I think in 2026, why things don't heal. Okay, and if you talked to me 10 years ago, I would have thought differently. And when I come back 10 years from now, it might be a little bit different. But I think that, in the mistake I made, traditional treatments focus solely on alleviating pain. So that would be, you might see a specialist, and I think part of it is our problem as podiatrists. Everyone's so busy. So you come in, you got 5 minutes with the patient, they have heel pain. What's the easiest thing to do? Just give them a cortisone injection or put them on a prednisone. And so a lot of times doctors are rushed, and they just do the quickest thing, see you back. And it's like a factory. They want them in and out to do that. That's what we do. That's our problem in our profession. So what happens is they get a little bit better, but you don't solve the underlying tissue damage. And this also often results in persistent symptoms, lack long-term relief, meaning it goes under the symptom line after the cortisone, and about a month later it comes back, and they try something else and it goes down, and they just have this cyclical approach. People try temporary solutions. They Google it. They try anti-inflammatories. They get temporary relief. It doesn't address the true source of heel pain. It can lead to a frustrating cycle, and the symptoms return. And then need a comprehensive care, a comprehensive approach plan that reduces mechanical stress and tissue healing. They have to seek treatments that promote actual tissue repair. I think it all is with tissue repair. You can't get new tissue. You can't like replace your Achilles or your plantar fascia. So you have to learn how to heal it. I want to address a few things that people ask me about. Patients come in and say, "Doctor, can I have a cortisone?" It can provide temporary relief, but once again, a cortisone isn't going to reduce the thickness of that fascia. And I want to be clear, a lot of times, even with Shockwave, you're not going to reduce the thickness. You're just going to take care of the chronic inflammation in the tissue. So once the tissue is scarred, it's not going to really come down, but it's not going to hurt anymore. And I'm okay if it doesn't hurt. You might still have that bulb in the back. You might have it, but when you squeeze it, it's not going to hurt. Okay, that's the issue. You can't really totally reduce. It'll reduce a little bit, but not a ton. And just to remind you, you can't do it in the Achilles. So Achilles tendon, you can't inject it because it can cause a rupture. So don't ever let anyone inject cortisone in your Achilles tendon. This is the big question that patients ask me. How active can I be and still recover? Okay, how active, what activities can I do and can I still get better? So I always say, be as active as you can without making anything worse. You should hard stop if you have swelling or limping, and don't do that activity, or limping, don't do that activity and take time off. If you have to Advil way you're through activity, you shouldn't be doing it. If you're having to take Advil to do a certain activity, you're doing too much. Continue if you have little pain in the beginning and it gets better. So many patients, hurts a little bit when I start running, and then all of a sudden it gets better and I'm fine afterwards. That's fine. Or when I'm walking, that morning pain, getting out of bed in the morning hurts a little bit, then it gets better. You probably need treatment, but you can do those activities. Okay? So some of the common treatments, I kind of box things into categories, and this is where I'm going to ask you guys to, I'm going to go through these. This is the exact thing I give to patients. So depending on what you have, could you help Aaron hand these out? He's going to ask you if you have plantar fasciitis or Achilles or both. And you can give this is the exact same thing. I just give it to my patients. Give me one of those here. Just one. Thanks. Okay. So when you talk about treatments, you can reduce the stress and strain, you can reduce the inflammation, and you can reduce the tightness. I like to keep it nice and simple in terms of categories. So reducing, if you look at my little paper here, I don't have everything on here, so I don't want to overwhelm patients. There are hundreds of treatments that you can do. To reduce stress and strain, I usually do either an orthotic to take pressure off of it, shoe recommendations, I'm always recommending shoes, and then my favorite thing for plantar fasciitis around the house is an UFO sandal. It's a sandal that has a really good arch support, and patients just love them. It doesn't solve the plantar fasciitis, but it makes them feel better, okay? That's how I reduce the stress and strain. Reducing inflammation. Many times I put people, if they haven't had it, I will put them on an anti-inflammatory. But I find if you do 2 weeks of an anti-inflammatory and the pain comes back, you can't live on anti-inflammatories, okay? Anti-inflammatories are temporary. That's not a solution, okay? I don't do much prednisone. I don't think prednisone is a great solution long term. You can do a contrast bath. That can help a little bit. And what I do for patients, and this is kind of a practice management thing, okay? So I'll tell you about this. When they come in, I'm not going to tell them to take Motrin because they've probably taken Motrin before, okay? So what I usually do is I give them something different that they haven't had. So I'll like try a meloxicam. And the reason I do that because it's once a day dosing. And the less people have to take something, the more they take it. So if you have to stretch 3 times a day or 1 time a day, what are they going to do better? The 1 time a day, because it's easier. So a lot of times I'll give them meloxicam that's just 1 time a day, and I keep it very simple. So you try that for 2 weeks, And if it's not getting better, then we go to the next step, and I'll explain that actual process. And then the other thing would be a contrast bath. Now, do I think anti-inflammatories for a chronic plantar fasciitis Achilles is going to take the pain away and resolve the issue? No. But in my profession, I have to start with the basics, and then I go to the more advanced things. Unless you come in, you've had it for 2 years, and you've seen 3 other doctors, and you've already tried different, then I'm going to jump right to step 2, okay, not step 1. Contrast baths. Once again, I like contrast baths. What that means is you use 2 buckets, a bucket with water with ice, and a bucket of hot water. You go 5 minutes in the ice, 5 minutes in the heat, 5 minutes in the ice. That can be for anything where there's swelling. It really helps it. It's something very easy for patients to do, okay, and they like it versus just plain icing. Once again, it sets you apart a little bit. They can just Google it and try icing, but contrast baths just seems a little bit cooler, okay? But these are the ways you can reduce inflammation. And then reducing tightness. This is where I have a little routine that I have my patients do, and it's written on here. And I like to be very clear with patients, and they get this little piece of paper, and I say basically in the morning before you get up, you're going to do a towel stretch or a TheraBand for 2 to 3 minutes. You're stretching. You put on your UFOs when you get out of the bed, and then I say you turn on your coffee pot and you're going to foam roll for 3 minutes. At the end of the day, you're going to foam roll for 3 minutes, or anything you want. You can do a roll, you can do a stick, you can do a Theragun, you can do it, anything you want, but I keep it real simple with a foam roller. And then you do a stretching splint for 3 hours. So stretching splint is called a night splint. It's something that just holds your foot up. It's used for both plantar fasciitis and Achilles tendinitis. Buy them on Amazon. You get them from your doctor. Makes your toes go numb, just so you know that's normal. Makes your toes go numb. And then they try that. Okay, that's how you reduce the tightness. So there are a couple of modern treatments that can be used to repair and heal. I've mentioned it a little bit. One is, this is an example of a radial pressure wave. Basically, it's a little bullet that runs back and forth here, and it hits the area of the injured tissue, and you do it for about 3 or 4 minutes. You do a number of pulses. So pulses would be like the same as a dosage. So for example, for ibuprofen, you could, normally people take 600 or 800 milligrams. There's no benefit to doing 2,400 milligrams. There's actually some harmful effects, right? If you do too much Motrin at once. Same thing with Shockwave. The research shows about 2,000 pulses at a certain amount of energy. That's what we do. We don't do more. We don't have to do, doing less, it's not going to do much. Same thing, this is called a focused Shockwave device. The main difference between these two devices, we had this one just for a number of years, and this is very good for about 80% of what I do in podiatry. So it's good for Achilles tendinitis, plantar fasciitis, metatarsalgia, peroneal tendinitis, posterior tibial tendinitis, all the itises that people have. This one here actually penetrates into the bone. So this is good for like a sesamoiditis or a sesamoid fracture or a bone that's not healing. It can actually stimulate the bones to heal. And something you need to know, sometimes if you get an MRI of an Achilles tendon or a plantar fascia, your MRI is going to show something called bone marrow edema. So bone marrow edema is swelling inside of the bone underneath where the injury is. So this can help that. It's almost as if it pulls so hard and they're walking different, it can cause that bone, that edema or the swelling inside of the bone. So this is my one technical slide. Okay, there's only one. Okay, it's going to talk about this so you can understand. You asked how Shockwave works. This is how Shockwave works. I'm going to simplify the words. It stimulates micro, so small vessel blood flow. So it increases blood flow to that tissue. Give you an example. I had a patient that had a really bad insertional Achilles tendon on the back of the heel, really big bump. I did Shockwave, and it didn't get better. So I want to be clear, not all my patients got better. And this was in the day where I was hurting them too much. I think I went a little too high, and she's just like, just do the surgery. The interesting thing is, though, I had done her other heel, so there's a procedure where you detach the Achilles, shave off the bone, and then reattach it. I had done that on one side, and she's like, and you know what, and this is for PTs, if patients have one type of treatment and it comes on the other side, they want the exact treatment. Even though there is a newer treatment that is better, they want the same treatment. So for example, I had this bunion, I'm going to exact same bunion, because it's patient expectation. So she just said, I just want it off. You did the surgery last time, just do the surgery. I'm like, no, this is better. I'm like, I don't want it. I just want surgery. I did some Shockwave, And when I opened it up, it was like filled with blood vessels. And her recovery was at least 50% faster on the other side because I had pre-treated with a Shockwave. That's why sometimes now what I do is I pre-treat with Shockwave. They have some research in dermatology where they do abdominal plasty, like surgery, tummy tuck. And they treat half of it with Shockwave and the other half without it. And if you look at the scar, even that one pre-treatment makes the scar look better. So it's really interesting how it stimulates your body's blood flow. It does mechanical transduction, which stimulates the cell matrix, which is inside the cell, how the movement of the cell, cell wall permeability. Substance P is the pain. It helps with pain. Has anti-inflammatory effects. It stimulates. This is the main key. It stimulates growth factors. So how do you stimulate your own growth factors? This is how you do it. Okay. So what that means, neogenesis. So means new production of vessels, of bone, and collagen. So this is like the fountain of youth, right? It's gonna, and if you go to these conferences, they're doing this for plastics. They're like on people's faces. They're like getting rid of their wrinkles. You know, it's a little out of my scope, but they use this for huh? Yeah. You know what? Yeah. It works for. I'm not going to talk about men's health issues. It helps with that. It helps with a lot of things where you need blood flow. We use it mostly for blood vessel formation to go into that tissue. Remember what I said in the beginning, there's no blood flow. So it helps with blood flow for bone, that bone marrow edema or swelling in the bone or fractures that are slow to heal, breaks in the bone that aren't healing. Like for example, we have a lot of athletes, they get a stress fracture, they're preparing for a marathon. The research shows the return to activity is 50% faster. I'm not saying that the bone heals 50% faster, because we all know that once the bone heals, the return to activity takes more time. What I'm saying is the return to activity is 50% faster because the bone heals better, quicker, and all the soft tissue swelling goes down. So we're doing this for like stress fracture for patients, and it just works great. And then in the tendons, which I just talked about, they're all mostly made out of collagen, so it helps the collagen to heal better. And it stimulates your own stem cells, and it breaks down scar tissue. And the last word is calcification. So what I mean by that is some patients, they have inside the Achilles tendon, if they get little micro tears, those micro tears cause bleeding, and that bleeding sometimes produces bone or hardening or calcifications. These calcific, you would talk about it within the PT realm of a calcific shoulder. Okay, we see a calcific Achilles tendon. Once again, reduces flexibility because you got bone in that Achilles. This works phenomenal for just reducing that tightness, both in the shoulder and in the Achilles. So this is the part where you're going to hold up your little piece of paper, and I'm going to answer any questions after this, but I'm going to show you exactly how I treat things. You can go ahead and ask your question there.
There are vibrating plates, and one example is called power plate. People stand on them. Can that have a similar effect from shock treatment?
No. Okay, nor does a Theragun, nor does E-stim, none of those do it. No. That they say that can help neuropathy, or that can help your balance, that can help blood flow, maybe, but not like this. Okay, these are like expensive machines, like $100,000 for these machines. They're expensive, so they do a little bit different. Okay, now I'm going to walk you through exactly how I treat. Imagine you were on visit 1, and if you've tried visit 1 stuff, then we're going to go to visit 2 stuff. So visit 1, this is what my patients get. I actually check the boxes off, and I say you're going to get anti-inflammatories, contrast baths, deep towel massage, foam roller, night splint, shoe recommendations, UFOs, and I'll see you back in 3 weeks. If you've seen 3 or 4 providers, you've probably already done those things. Okay? Then you would come to phase 2. Now, a couple of things I want to point out. I put on here some additional treatments that sometimes we need, and then what patients really like is when I cross it off. I'm like, I don't think you're going to need surgery. I don't think you're going to need an AFO. I don't think you're going to need a cortisone. I don't think you're going to need an MRI. So I cross that off. But in this list, I can get 99% of the patients better. Okay, with this stuff on this list. Now, there might be a few other things you could add in. So I try that first. If they're not better in 2 to 3 weeks, all I do is an ultrasound. So if they've tried all that stuff, I'll just jump right to the ultrasound. In the ultrasound, it's really simple. Like I just told you, I'll look at the right foot and I'll look at the left foot. If the right one is, and I show them, I show them 2 pictures. This is your right, this is your left. So the left is thickened. The left has lost elasticity. So if that happens, then if the ultrasound is abnormal, this is commonly associated with heel pain, we're going to focus on reducing the swelling and the fascial thickness. Then basically my patients get 6 sessions of Shockwave. If there is a tear and they're older, they're going to get an amniotic stem cell at the 2nd visit. And then at the 3rd visit, I'm going to scan them for orthotics. The reason for orthotics is to prevent it from coming back. In the beginning, in my opinion, if you do a rigid orthotic at the 1st visit, they're going to get it and they're not going to tolerate it. It's going to hurt too much. Okay? So that's the biggest problem with orthotics, is they're uncomfortable. And they're uncomfortable because nothing hurts, nothing feels good. And I always say, well, okay, the right foot hurts. How's the orthotic feel on the left? Oh, it's fine. Well, the problem isn't the orthotic, the problem is the foot. Okay, once the foot feels better, then an orthotic. In some, if they have abnormality like pronation, that's where it's more beneficial. So that's how I treat plantar fasciitis. If the ultrasound is normal, okay, sometimes it's normal, then that's where I would say you could try a cortisone injection. Fascia is normal, hasn't changed. They're going to Disney. They need to feel better. I would do a cortisone. Or they went to Disney and they came back and their tissue is normal. I would do a cortisone for that if they're limping around. Usually those people are limping. I always say cortisone 8, 9, or a 10 on a pain scale. That's who I do cortisones for. Then that's where I would do physical therapy, right? Because the issue is probably due to the tightness that caused it. The tissue hasn't been damaged yet. Calm them down. Because the thing is, if they're limping, they're not going to be able to do PT. Okay, so calm them down, get them into PT, and then do an orthotic to prevent the recurrence if there's usually a structural issue. That's how I do plantar fasciitis. If it's chronic, meaning I've tried that, it doesn't work, then I'll consider an MRI, then I'll consider a brace, then I'll consider surgery. I say I do this maybe 1% of the time, very rare. Achilles looks exactly the same because I think they're the same structures. I do the same thing the 1st visit. Ultrasound abnormal, I do the same treatment. It's because it's same tissue. And then if it's chronic, I'll do those other things. Okay, so I'm here I can examine anyone. If you want to come up here and I'll push at your foot. I can answer any questions now. Hope you guys found this beneficial. Go ahead.
Why the 6 Shockwave? Is that kind of just been found to be like
Yep.
the magic number of what's
Yep.
really been consistently
So
helping?
in the beginning, I used to do 3. So so when you look at all the research studies, they tend to do it on 3. I think they do it 3 because you don't have to spend it because they're not charging for it, right? And so that's a cheaper number to do. So a lot of the research studies, they come out with 3. What I found though, a lot of times with 3, they came back 6 weeks later, then I'd had to do a 4th. And then they come back again, I have to do a 5th. So I have to add more. But it's between, I usually say to patients, between 3 and 6. A lot of it depends on how long you've had symptoms. So I would say if it's been, I used to say this, if it was under 3 months, I would just do 3. If you've had pain over 3 months, then I know it's more chronic, then I would tend to move towards 6. But if it's under 3 months, a lot of times the tissue doesn't even warrant it because the ultrasound's normal. That's why, because it's turned into a chronic state. But it just depends on, it's even preference of the practitioner as well, what you feel comfortable with.
Can people buy their own Shockwave
Yep.
and use it
You can.
for whenever
Mhm.
they hurt anywhere?
You can. And Holy Cross owns one. Everyone I talk to, I tell them ballet departments own them. All the professional football teams, soccer teams, and they all do it.
Is it harmful to just use it if you're hurting somewhere?
So the radial machine, the radial one, which is just the sound waves, which is about $20,000, you can buy one, and a lot of the teams have these, and there's no harm. A lot of people do it. I think in the future, frankly, it's going to start being considered natural doping. Because they've done research studies, for example, not even research, but people tell me they do like a marathon, and they only treat one quad after the marathon, and they can go upstairs a lot easier 2 or 3 days after. So like the post marathon, like I think if you were gonna, as a PT, you could say we got a marathon prep. We do 3 sessions before the marathon, a couple sessions after. It's almost like doping because it helps so much. It's not considered doping yet. So that's the pressure waves. The one that is focused is electrical, and it's about $60,000. And that one, you really need to know where you're putting it because that has bone penetration, and that can actually cause scarring if you don't use it right. Okay, so that one's a little bit, but people do buy them. I know one of my colleagues, he bought one because he just, you know, as we get, it's really the older ones. You know why my partner is Neil Feldman, okay? So I'm always doing, like, he's like, Don, can you just do my hamstrings? Like, can you do I'm always doing Shockwave on the guy. And, you know, he bought it because he's getting older and he's trying to do these ultra marathons and things break down. So I always say, if you're an older athlete, you need 3 things. You need a good shoe store, you need a good PT, and you need a good podiatrist, because things break down. It's a trait. It's not a problem. It's the mechanics. And so he's always having things. I'm like,
you could technically use it the whole body.
and so that's why I tell PTs, you guys should buy one of these because you have a bigger scope than I do. So calcific shoulders, backs, chiropractors are doing it on the back, lower back pain. You're going to do it on the hip. I think in the future there is going to be strip malls with Shockwave, with practitioners, and you go in, and it's not going to cost $250 a session, or probably be $150 because you have a tune-up. Yeah, and it helps for wellness. It can help for, and that's what the footballers do. The football players, they're going to do it post game, like the same way you would do icing, the ice baths. You're going to do this because it just helps your soft tissue recovery.
I was wondering about your shoe inserts and shoe changes. I have an 8-inch
Lift.
shoe wedge
Mhm.
in my right foot, and that's where I'm getting plantar pain in my heel.
An 1/8 inch you have? An 1/8 inch?
An 8-inch.
Okay.
Because one leg was becoming to be shorter than the other,
Okay.
and I'm well into your, I'm well over your 50 to 60 inch age range. So I'm
Yeah.
just not sure.
And so you have heel pain, bottom of the heel pain?
Yes.
Okay. So I find, and what the research shows is an 1/8 inch is very small. Normally, 1/8 inch we adjust in our hips. You don't even need a heel lift for an 1/8 inch, okay? You can wear a heel lift, but these micro little we call it limb length discrepancies, that's what we call it. You can do a lift, but that doesn't usually cause heel pain. So the limb length, you've probably had this going on for a long time. Usually we adjust our hips or our back, but putting it in there is fine, but there might be something else going on. So if it's, and there, I didn't talk about central heel pain. The heel pain I'm talking about is call it in the bottom inside, plantar medial. The central a lot of times can be like a bursitis, it can be other things. So you probably have it ultrasound. That's what I would probably recommend. Let's take a look at it. Okay. So that is my contact. This is exactly how I treat it. So I always recommend print this out. If you're seeing a doctor, just ask them if they've tried these things. And you can use it. You can use it yourself, and you can just check and hey, and sometimes they don't offer all the treatments. That's the challenge. So let me explain. I'm in private practice, okay? I can do whatever I want, okay? If you work for a Reliant or a UMass, you have to get approval. And that's the challenge. And they can't get $100,000 worth of machines approved by these big institutions. That's why a lot of times they don't have them. Now, if you go to, for example, a Spalding, right? There's Dr. 1040 who does all the research on this stuff. He is a physiatrist, okay? They own them over at Harvard. So they're doing all the research on them. They own them. They're using them. So it's going to gradually kind of move our way and do it. I think other doctors are going to start doing it, because I think it works great for getting people better.
What's the cost of these various treatments?
So it really depends on the doctor preference and how much. You can charge whatever you want, okay? So the machines are a big investment. So it's anywhere between $200 to $250 per session, okay? So that's for the Shockwave, and then the amnio is whatever. It's between $800 to $1,500 depending on the patient, the preference.
That's a one-time injection.
The injection is a one-time injection, yeah. But I do a lot more Shockwave than I do those injections. I do very, very few injections.
Obviously, everybody's different, but like, what are you seeing for long-term effects? Like, how long are people getting pain-free?
Yeah, I haven't. They're not coming back.
So that's good.
Yeah, they're not coming back.
And if someone had to come back, right, would you still recommend another 5-6 sessions, or would you say let's try one?
I call them touch-up sessions. It's kind of like when you paint, you might just do some touch-ups. So when I see them back, I see them for follow-ups at 6 weeks. And if they continue to have some pain, I do a free touch-up, I call it. Then I'll see them 12 weeks later, and then I'll do a little touch-up. And if it's not better by that second follow-up, then I have to I may do an MRI. There might be something else going on. And so, but usually by that second one, they're better. Now, depending on how thick the tissue is, it might not go back to totally normal. So once again, it's setting patients' expectations. You might still have some little bit of tenderness in there, but because it's just thicker, it's like a 3 rubber bands versus 1 rubber band. And so they're still going to feel something, like barefoot might be painful. When they do a lot of activity, it might be painful.
What about if you were doing the therapy,
The Shockwave?
And it's like every 6 weeks, you're saying?
No, so I do Shockwave once a week for normal people,
Okay.
normal non-athletes. So athletes, I do it every 3 days, every 72 hours. For regular people, I try to get the 6 sessions in within an 8-week period.
Okay.
So, because, depending on people's schedule and things like that.
And how is it in between, like, if we walk the dog
Yep.
3 times a day. And
Yeah.
take it out, and I force myself on that walk.
Yeah.
It's painful, but it's like,
So you're into that category. I said, how much is too much? So people with Shockwave, there is an inflammatory. So one thing about Shockwave you need to know, you can't take any Motrin or ibuprofen when you're doing the course of the Shockwave, because I am causing inflammation, and if you're taking an anti-inflammatory, it goes against it. So a lot of times there's some natural things I do, like a turmeric type of a thing that they can do that equivalent to like a Motrin. But in terms of activity, you're going to have a little bit more pain for 72 hours. That's the inflammatory. And then you repeat that a week later, that inflammatory. Every time you do it, you're re-injuring it, giving a dosage of energy in there that's injuring the tissue, and that it's going to hurt for 72 hours. Not really bad, right? Once again, you're in the yellow scale, but you're going to be noticing it, and you're supposed to notice it because that means your inflammatory system is working.
would you be better off staying up?
No, you can do anything. You can do anything. I always say if your pain isn't above a 5 or a 6, you can do anything you want. If you're the problem with walking when it's hurting is you're limping, and like you're going to throw your hip off or your knee off. Like the Shockwave, you're not going to mess up the treatment. The treatment's going to continue to work despite us, because it's your body. But if you're going to throw something else off.
I have a question.
Mhm.
You had referred to
Core stability.
Is there one that comes first over the other? Like, would core instability subsequently cause plantar fasciitis?
Yeah.
Or would painful feet cause
Mhm.
the weakness of,
Yeah.
inactivity?
I really respect PT, so I tend not to tread on their territory, but from the little I understand, usually the problem is more proximal. What I mean by that is the problem usually starts up here, and then it usually leads to symptoms down there. So that's why a lot of times I'm sending to PT, and I'm saying they're probably not going to look too much at your foot. They're probably going to look at your calf and at your hip and at your core and on your breathing.
Yeah, that's what
And
I'm thinking, like,
so they have to work all that. So if that's off, yeah, it could be pelvic floor. There's other things like that you have to look into. Yeah, if it's, yeah.
In your own practice, in terms of like the past decade, have you noticed any new trends or new activities that has increased the rate of Achilles or plantar fasciitis? For example, with the rise in popularity of like pickleball in this state particularly, there's been an increase in older population participating in activity. I don't know if you've noticed an increase.
I have, just like you have. So pickleball is the best thing that ever happened to us in podiatry. Like I just want them to put I want to rent a billboard with my face there and say, you got foot pain, come see me. Because yes, but let's look at why. It's because you don't have 20-year-old tissue. You have now 60 to 70-year-old tissue. You haven't used that tissue. That tissue is like a old rubber band that's dried out, and there are a lot of injuries. Not just foot though. You're gonna more so. There's going to be hip. There's going to be plantar fascia. There's Achilles. Things like that. I'm seeing that's one. The second thing is I'm seeing patients are just tending to be more active and they're healthier longer. They're living longer, and they're trying to be healthy, and so that's another thing. Good. So I am free to examine anyone. If you want me to push on your heel or your Achilles, you can come up, lay down, sit down. We can do that. And anyone else, you can stick around if you want. You want to say anything else, John?
No, just thank you, Dr. Pelto.
Hope that was beneficial.
And I can indicate, as you can see by the presentation, that Dr. Pelto is one of the premier podiatrists, if not the best podiatrist
Oh, thank you.
in Massachusetts. So hopefully you get a chance to talk to him.
Yeah, we all have some that don't work out either way. We're all the same. So thank you, guys.